So Michelle, we're talking about some of the exciting new drugs that are available in ovarian cancer, and you're on a Parp inhibitor. And I want to share some of the decisions that we went through in terms of deciding Parp inhibitor when and which one. And so I want to go back to when you finished your second-line treatment with chemotherapy, you were on the bevacizumab, and we did maintenance bev. That was actually a while ago, and I don't know if you realized this at the time, but none of the Parp inhibitors had been approved for maintenance yet. So it wasn't even an option that came up for us then.
I remember that. I think it came out December 2016.
Right. So now it is an option. And if we were to go back in time, would our decisions be different?
That's a good question.
It's always hard to know.
Yeah, I'm just glad that it came out when it did.
Right.
Yeah.
So right now, there's two drugs, two Parp inhibitors that are approved in the maintenance situation. And those are olaparib and niraparib. And the approval for those Parp inhibitors in that maintenance situation, when somebody has platinum-sensitive chemotherapy and they responded to their chemotherapy with either a complete response or partial response, is for all comers. So you don't have to have the mutation.
Oh,
you
interesting.
have a BRCA1 germline mutation, right? So in this situation, any patient who is platinum sensitive who responds to that chemotherapy can go on a Parp inhibitor for maintenance treatment. And in somebody who has had a BRCA1 or 2 mutation, either a germline mutation like you do or a mutation just in the tumor, the benefits in terms of disease control are pretty outstanding. We're talking not just twice as long, but almost 3 times, sometimes 4 times as long. Yeah, it's pretty dramatic. If I give you the numbers, it doesn't even really pop out in terms of the improvement on the curves, but we're talking 19 versus 5 months, 16 versus 5 months. I mean, it's
huge difference.
Huge difference, right? And there's some differences in terms of how you assess that data, but bottom line, it works, right? If somebody doesn't have one of those mutations, but let's say they have another mutation that's associated with homologous recombination defects, there's still a benefit. It's not quite as strong, but it's about I think it was about a 6 to 9 month benefit in those situations. And again, you have to take these numbers with a grain of salt. Bottom line, though, it does work in that situation. And then if somebody doesn't have the mutation at all, the benefit is less. It's about a 3-month disease control, but you have to be careful with the numbers because the other things they talk about is hazard ratio. So you're basically decreasing the risk of disease coming back by, in some cases, 40% if somebody doesn't have the mutation or the homologous recombination defect.
Okay.
I gave you a lot of information there.
Yeah.
As a patient, what do you think of when someone tells you all this?
But as a patient, you go by statistics a lot because you want the best treatment that you can possibly get. So if the statistics are looking good in my favor, then that's my decision. That's what I base my decisions on.
And with the BRCA1 mutation, it would look really good to get one of these drugs. So they weren't available for you at the time. We did bevacizumab, which I think makes a lot of sense given the data. You recurred, and at that point that or not recurred, but progressed, at that point we did talk about the fact that there was a drug available now called rucaparib. That's a different Parp inhibitor. Rucaparib is one of the Parp inhibitors that's been approved for treatment. All right. The other Parp inhibitor that's approved for treatment is olaparib. So I just want to go over this again because it's very confusing.
It is very confusing.
Right. There's 3 Parp inhibitors. They have different indications from the Food and Drug Administration about when you can use them and in which patient you can use them.
Interesting.
It's almost like I need a big table here to
show it up.
But just to go through them again, the maintenance indications are for niraparib and olaparib, and the treatment indications are for olaparib for patients who have a germline mutation
like
only,
me.
Yes, like you, and who've had at least 3 prior chemotherapies. And then the other one is rucaparib, and that's for patients who either have a germline mutation or a somatic mutation. That means a mutation just in the tumor. They didn't inherit it from a parent, but they have a de novo mutation in the tumor and have had 2 prior chemotherapies. So actually, you can use rucaparib sooner than you can use olaparib. I think at some point, these distinctions are just going to be a wash, and all these Parp inhibitors are going to be approved across the board.
Oh, good.
But right now, good is right?
Yes, we need it.
But right now, how we make those decisions is really based on the indication, the tumor biomarker, the genetic germline mutation biomarker. So it's really important that patients have the conversation with the physician about which one of these PARP inhibitors, if any, can I get? And that's one part of the treatment decision, right? And then the other part is the side effect profile. So in your situation, we had rucaparib as an option, and we went for it.
It actually came out available right when I needed it.
It was perfect timing.
It was very perfect timing.
And what are your experience been on rucaparib so far?
The side effects have been minimal. I have drainage in my eyes and my nose, abdominal cramping once in a while. Fatigue is still there, and that's pretty much about it.
Right,
I'm doing really well on it. Sometimes I get nauseous and I can't eat, but.
So I remember one time asking you, how do you feel on this drug compared to everything you've gotten in this whole experience?
It's the best I've felt in over 4 years.
Yeah,
my quality of life is really good right now.
And that really struck me because it was the best you felt in 4 years. So that included that time that you came off of any treatment and you were in your first remission. This is the best you felt.
This is the best, even when I was in remission for 6 months.
So that's
how well this drug's working with me.
Right. And I think that for some patients, these drugs could potentially represent a cure for someone with platinum-resistant or platinum-sensitive recurrent ovarian cancer. They've had some patients on these drugs long-term, and one of the studies, which is study 19, which is an olaparib study. So they have now data going out 5 years, and there's a few patients that are long-term survivors. Yeah, so it's very exciting. Yeah, you're doing
that's
great.
Really good news.
Right. Michelle, going back to when we talked about starting on a PARP inhibitor, we knew that option was potentially coming months before it was even available. And I know your daughter even knew it was coming.
I know,
right?
she works for a clinical trial company.
Right.
Yeah.
She's very smart, and she was very interested in PARP inhibitors for you. But not everybody knows about these drugs, right? Maybe some of our patients don't know about them. Maybe some of their doctors don't know about them either. I personally think the PARP inhibitors and their approval in ovarian cancer is the most exciting thing we've had happen in years.
I agree.
I mean, it's transformative. So I would like to just shout out to all the patients to have PARP inhibitors on your radar. Ask your doctor about them. See if you're a candidate for these drugs. And then when you're making decisions about which drugs to use, discuss the side effect profiles, how many pills you have to take, and obviously the cost. Would you add anything to that?
That's perfect.